next presentation is on the verge of possible. The results of a surgical treatment of the eye, which result is satisfactory. Hello, everyone. I am grateful to the organizer, to Volodymyr, and to the Association of Ukrainian Ophthalmic Surgeons. This topic is very important to us these days, and I'm grateful for your work, for your support. We have worked together on multiple occasions. We have received some humanitarian aid from you. And right now, let us step aside from surgery and consider some statistics. So, what are the acceptable results of surgical treatment of patient with combined combat trauma? This is a question quite often asked by us surgeons and the families and the patient. Could we do better in some specific situations? And yes, let us discuss this topic. So, this is the Birmingham eye trauma terminology. I believe you are aware of this. It's a classification based on perforations and the external objects. And we can see the numbers from the different wars of the 20th and 21st century. So we can see the increase in the latest wars in Iran and Afghanistan. And let us compare to the more recent data from Turkey. This is something that took place even closer to our time. So, yeah, our Ukrainian data is 15%, yeah. We unfortunately don't have the specific percentage of the eye trauma because, well, only after the war we will have the full access to all the documentation and be able to discern between the military and civilians. But yeah, I would say that these numbers are 95% accurate. Also, the penetrating wounds, if we compare this with the American data from Iran and Afghanistan, it is well, quite similar to what we have, but the difference is that the war is now very different. There are drones happening very close to the combatants. The speed of those fragments is very high, and thus the damage done by them is very high as well. As we have mentioned already, there are large percents of bilateral damage. Again, we are quite close to what was shown by the US and Turkey. So these are the reasons that the mechanical, hydrodynamic, thermic, chemical, and molecular damage, and this can entail some serious damage to one's vision, as one's external eye layers are damaged, and also the vessels and the eye nerve, and there are some issues with the blood circulation and large traumatic macular disruptions. And as we have mentioned, today there is OTS developed by Ferenc Kohn and his colleagues, and they did this based on the classification of 5,000 patients. Please pay close attention to this first category, we are assessing the initial visual acuity, and we get these numbers. So light perception is in most cases, those who do not have it will remain blind, but only 15% will have some vision, and the lighter the injury is, the better results we are getting in terms of treatment. Also, we have here some American data from the operations in Iran and Afghanistan. So we have 92% of no light perception after the treatment. Only 7% have the chance of making it to the next category, out of which 39% can remain blind after treatment. So I am showing this line in bold, and I will tell you why. And so until later we have the final percentage of those who will have vision at the end of it. This is a data from the same war, but from later years, and these are the external object injuries, and again, in the bottom we have no light perception. We had also those who lost this ability after the treatment, those who had external objects, and some are responding to the movement of hand. So we can see some people switching from one category to another, and we can see that compared to 33% in the previous table, we have 41% of those who have some remaining vision. This is the data from Turkey, and we can see those responding to the movement of hand and basic movements. And there are also some data from Pakistan. This was their counter-terrorist operation. Again, the assessment is based on the trauma score. And just not to overload my slides, I am showing that they are experiencing the increase of the percentage of blind, but there are also those who are advancing in their possibility to respond to light. And also there is ultrasound examination of what is happening in the eye, and if we see this picture, most probably we cannot hope for good results. This is an example of protective goggles. Of course, they can save lots of eyes, and there are no questions about this. But there are two different standards, the American and NATO standard. The speed of the fragments is 105 meters and 200 meters respectively. But below this, you can see the IED fragments speed, and again, these are the fragments of the explosive charge, and yeah, as we can see, their speed is maybe 6 times higher, and this is why they can easily break the protective glasses. So most probably, if the explosion is very close to the combatant, the damage will be quite serious. So these are the reasons of blindness. in the eye, and I did my best to mark things in the same color if they could be grouped, and they have here the ruptures of the um, vessel surface, and also the atrophies of the eye nerve, the enucleations, the serrations, multifactor, etc. Um, Also, detachment of the detachment of the retina, and this is what we can see in the eye, and sometimes even in the pre-operation period we understand that the chances are lower, but we still do this because quite often it's the only eye remaining after evacuation. These are the main consequences of non-satisfactory results. This is the MI5 version, and we can see the data from the Turkish militaries, and we can see the subatrophies of the eyeball. We can see the percentage of enucleations and eviscerations. And yeah, I would like to emphasize here that according to the data from the earlier article on Turkey, there was a very high percentage of those with primary enucleation, and a couple of patients with secondary, so over 30% of such patients with eviscerations or enucleations. And also, when we have to transplant the cornea, we also have to be creative at times. I want all of us to understand where the differences come from. Well, the severity of damage, that's the most essential factor. There is a big number of combined injuries. There are delays in evacuation. There are some issues with receiving comprehensive surgical aid. Also, the compensatory mechanisms of these patients are exhausted, especially if they have limbs and their visceral cavity damaged. And also, we can see big numbers of external object injuries. The only reason to be optimistic here is the percentage of endophthalmitis. That's most probably because of the high kinetic energy and high temperature. This is why the number of endophthalmitis cases is rather small. So, I encourage all of us to remember and use this because there is a possibility to improve vision in the eyes, although it is quite low in many cases, but sometimes it's the only hope for the person to be able to see at least some light. So why am I focusing specifically on one of the lines of the table? That's because there is a possibility to achieve the result in those patients if we correctly identify them. Some patients are getting their light perception restored after the surgery, some period after the surgery. We only do the most necessary things in the primary surgery, and we continue with the subsequent stages later. There are primary repair of damage that on the more highly specialized stages this can be addressed. We are lacking data as of now, but for sure this is a topic to work on. We also need to be careful if the patient has no other eye, especially if the patient has some infections. We should not rush with the operations on the remaining eye because the consequences can be quite dire. We also need to closely watch the patients after the operation. Quite often they would need additional correctional treatment. Thank you so much. I did my best to speak as fast as possible.